Okay, good evening, everyone, and welcome to the fourth Fungal Frontiers webinar of the year. I'm Ban Hock from the Singapore General Hospital, and my co-chair is Dr. Sharon Chen, who's from Westmead in Sydney. These Fungal Frontier webinars are a collaboration between the Asia Fungal Working Group as well as the Australia and New Zealand Mycosis Interest Group. And we're very happy to bring you this educational event, which we hope is occurring at a decent time for all the people in our region. It's my greatest pleasure now to Sharon. Please, Sharon.
Thank you, Van Hock, and welcome everyone. And we're really excited to have the webinar tonight on a slightly a lateral topic, but nonetheless very important, which will be spearheaded by Dr. Narut Chancharussin, Dr. Dillon Yeo, and Dr. Cherie Gan, who will do 2 case presentations and a number of lit reviews. In addition to this, we have Professor Monica Slavin and also Professor Ariya Chindamporn. Monica's from Melbourne in Australia and Ariya is from Bangkok in Thailand, who will be the members of the expert panel. So without further ado, I would like to invite Dr. Narut to present his case, and we will take a break when he gives us the signal to in his case presentation. So sit back, and I hope we all enjoy this. Thank you. Over to you, Narut.
Okay, and good evening, everyone. I'm Dr. Narut from the Sira Hospital, Bangkok, Thailand. And I will present the first case. Okay, and let me share the slide. Okay. Okay, and for the first case, this patient, he is the 72 years old Thai male. He is a retired government officer living in the Bangkok, and he was admitted to intermediate cardiac care unit on the October 12, 2022 on last year. And the reason for discussion today is a new pulmonary lesion that was detected during the hospitalization. He has multiple chronic comorbidity, including the diabetes, hypertension, chronic kidney disease 3, and ischemic heart disease. And the onset of the disease is about 10 years ago. And at that time, he was underwent the intervention such as a primary cutaneous intervention and also the AICD at the 6 years ago. And last, transthoracic echocryography showed the ejection fraction is about 20% at last year. And as shown in the slide is his current medication as shown. And for 4 months prior to this problem, he has a progressive dyspnea for 1 day. And for the physical examination, show the feature of the cardiogenic shock. And at that time, he was admitted to the cardiac care unit. And at that time, the doctor give him like a dobutamine and other inotropic drug, and also get him the intra-aortic balloon pump for the cardiac support. But the clinical is not getting improved. And after that, he developed like a kidney failure and initiated the renal replacement therapy. And 2 months later, he underwent the autotrophic heart transplantation. And at that time, he was induction by the methylprednisolone, MMF, and basilizumab. And for the maintenance, immunosuppression is the prednisolone, tacrolimus, and the MMF. He also received the antimicrobial prophylaxis, which is the fluconazole and cotrimazole for the invasive fungal infection and PCP prophylaxis, the time as shown on the slide. And for the CMV preemptive therapy, he was monitored CMV virology weekly. And according to the serology testing, both of the donor and recipient show the CMV IgG positive, and the recipient also has the immunity to the human simplex virus and also the varicella zoster virus. After the transplantation, he developed many of the complications after surgery. The first one is the CMV viremia. He had a CMV viremia after the transplantation, and he also had the neutropenia for a couple of days. And after that, we give him the ganciclovir for the 14 days, and also give him the GCSF. And after that, his neutropenia is getting improved, and the CMV viral load is getting low around 200 and 600. And after we stopped the ganciclovir one day, he also developed the acute abdominal pain, was diagnosed with the polymed-induced colonic necrosis, and he was underwent the ileocecectomy and do the colostomy at that time. And he also had the E. coli ESBL septicemia after he got the surgery, and the meropenem was prescribed for the 14 days. And on the early of the February, he also developed the Enterococcus faecium in septicemia, and the doctor prescribed the vancomycin and the linezolid after the ASC result is come back. And the last about, he also had the post pericardiotomy pleural effusion, which managed by the percutaneous drainage. And at this time, he also on only the immunosuppression, only the tacrolimus and the prednisolone, the dose as shown. And here is a follow-up of his chest X-ray, and you can see that on the early of the January and the last of the January, there is no any of the pulmonary lesion beside the pleural effusion. But on the early February, he had the new of the left pulmonary nodule, as shown here. And for the early of the February, he has no any of the fever at all. And he also had no respiratory symptoms such as the cough, dyspnea, or the chest pain. After we saw the a pulmonary lesion on the chest X-ray, we performed the CT chest, and it showed the focal consolidation at the subpleural region of the lingular segment. The size is about 2 centimeters. And here is a problem list. He is a 62-year-old man known case with diabetes, hypertension, and chronic kidney disease with the cardiomyopathy. Was underwent the autotropic heart transplantation, which is the post-transplantation day 56. And he developed the new left pulmonary nodule and also have the many of the post-operative complications. And at this point, I would like to invite the panelists to discuss about how to approach to the pulmonary lesion in the immunocompromised host, such as the solid organ transplant recipient like this case.
Oh, thank you. So I might just start off. So this is
sorry, Monica, I was muted. But yes, please.
Thank you. This is a pulmonary nodule that's developed fairly early post-transplant in a man who's had a lot and stormy history. He's had CMV, reactivation, some neutropenia, renal replacement therapy. So he's got a lot of comorbidities. So I think this is an early fungal infection potentially. I would be thinking of things, again, like aspergillus that may be secondary to the enhanced immunosuppression due to his CMV. I'd be thinking about other mold infections, and then just broadening out a little wider, it's not really the timing to see Cryptococcus in this situation, I don't think, but we do think about Cryptococcus in solid organ transplant recipients, but generally occurring later after transplant. And then I would also have a differential of non-fungal infections. He's had bacteremias, so he could have had a septic embolism or a bacterial pneumonia secondary to his bloodstream infections. And of course, there are other infections such as Nocardia as well that he would be susceptible to. And unusual organisms, bacteria such as Rhodococcus, etc. So I'd be keeping a pretty broad differential diagnosis and probably moving to some diagnostics like a bronchoscopy as well as some antigen testing and on his blood.
Thanks, Monica. That's a very comprehensive list. Ariya,
I have something. I think how
sure.
about the serology? Is there any sputum or you test on the
So you would like some diagnostic tests?
antigen test or antibody test? I think the Ariya might be for the.
Okay. Apart from any antigen tests or antibody tests, would there be any instructions for the resident staff to, perform procedures or organize various diagnostic tests?
I'm not sure whether there is any other lesion on the skin.
So always have a great look. I was going to ask you, Ariya, or Monica, for that matter, does the appearance of the pulmonary nodule help you? Is that a clue, or is it, not a clue? What's your opinion?
To me, seems a little non-specific. I think, there obviously can't really see ground glass around it, but that's because the patient's not neutropenic. You won't see that unless the patient's neutropenic. So it could be a fungal infection, but equally it could be a septic embolus, it could be bacterial. It really is non-specific, I think.
I do agree with you, Monica.
Badhawk? Thoughts from you?
Actually, I think Monica has covered most of the differentials. The only other thing I was thinking of is that if indeed this was Aspergillus, then it would be nosocomial, right? He hasn't left the hospital for is it 3 months or 4 months, which would trigger that there'll be a need for some infection control measures and investigations. But I think fungal is quite likely. It's nodular. And as for investigations, Ariya, I think it's really close to the thoracic wall. So it should be a mean to a transthoracic needle biopsy.
Is that possible?
A little under 2 centimeters. Some people say will pose a little bit of risk. But the fact that it's abutting the pleura should make it quite safe.
May I ask another question? This patient is still in the hospital, or he has any exposed to any environment?
I don't know that. Dr. Narut.
At this time, he admitted to the cardiac care unit. He never he's still in the hospital after the surgery and never go back to home at all the time.
That is 3 months, right?
Yes.
How long for that?
3 months.
And how?
And he admit at the hospital for 4 months.
4 months.
Yes.
Okay, so I'm hearing that there's a broad differential. We need lots and lots of tests, including a possible needle biopsy. We're worried that it could be nosocomial if he has been in hospital, and that we think it's probably a mold infection. Would that kind of be very high-level summary. Nod,
Yes.
yeah, or shake your head.
Yeah, it is.
All right. Banok, do you have your... No, it's okay. All right, Dr. Narut, can you please proceed and maybe put us out of our misery? Oh, second
And me,
case.
okay.
Okay.
So, hi everybody.
So-
My name is Dillon, and I'll be just presenting the second case from Singapore General Hospital. So, Dr. Narut and myself will be going a little bit back and forth as we tease and provide you guys with a bit more information. We have with us a 70-year-old Chinese gentleman with otherwise minimal past medical history with good function. He was first diagnosed in January 2023 with acute myelomonocytic leukemia, where he presented with exertional dyspnea as well as shortness of breath. At the point of diagnosis, he was treated with the IA 3+7 protocol, and this admission was complicated by a cutaneous HSV1 infection, as well as a sternotrophomonas bacteremia. After that admission, he will subsequently receive 3 cycles of azacitidine and venetoclax, and all the way until September, where repeat bone marrow showed that there was a relapse with new FEAT3 mutation. In view of this, he was started on gilteritinib as well as venetoclax. Later on, in October 2023, he had a prolonged stay for E. coli bacteremia that was complicated by septic shock, and he also had a left upper limb cellulitis that was precipitated by a noradrenaline extravasation injury. Later on, after his infective events, gilteritinib was resumed from December 2023. Venetoclax was held off. So we're now in April 2024, where he electively admitted for haploidentical allogeneic stem cell transplant from his son. So these are the transplant details. His plan for haploidentical allogeneic stem cell transplant from his son, HLA 6 out of 12 matched. With regard to the CMV serological status, both the donor and the recipient are positive. And so the day 0 of the transplant is on the 25th of April. The conditioning regimen that they're using is with thiotepa, fludarabine, and busulfan. And the prophylaxis that he was started on was ciprofloxacin, caspofungin, later switched to posaconazole, as well as acyclovir. So this is a timeline starting from his day 0 of transplant, as you can see in the red arrow. He develops an episode of neutropenic fever on day 2 post-transplant and was cultured and covered with intravenous cefepime. Microbiology as well as chest x-ray were unyielding, and the fever was deemed due to be some possible mucosal translocation. The fever responded with cefepime, and he was eventually switched back to his antimicrobial prophylaxis from the 2nd of May onwards. However, he develops another episode of neutropenic fever, this time associated with cough, breathlessness with desaturation requiring oxygen supplementation. Antibacterial cover was switched from ciprofloxacin to tazocin, and at this point, the patient was also recently switched from caspofungin to posaconazole antifungal prophylaxis. In view of the new respiratory symptoms, a chest X-ray was performed which showed a right hilar mass with opacification. CT thorax was also subsequently performed, which showed the presence of a cavitary mass-like consolidation in the anterior segment of the right upper lobe. So this is what we're dealing with. We have a patient with a relapsed AML who's admitted for haploidentical stem cell transplant, who now has a recurrence of febrile neutropenia with development of respiratory symptoms with a mass-like right upper lobe consolidation with internal cavitations. And the suspicion then was for invasive fungal infection. So this is just another timeline just to show the events that happen. So quite quickly after the chest X-ray was performed, the CT of the thorax, which we saw, was also organized. And then we were quite thankful to be able to get a bronchoscopy organized very shortly after. But very quickly on the 10th of May, just a few days after the onset of fever, new abdominal nodules were identified and a skin biopsy was performed. In view of these new nodules, there was a concern of fusariosis, so posaconazole was switched to intravenous voriconazole. The patient actually engrafted with neutrophils shortly after that as well. However, after a switch to voriconazole, the patient developed visual hallucinations promptly. He was switched to intravenous ambisome at 5 milligrams per kg every 24 hours in view of intolerance to voriconazole. And my MRI brain was also subsequently performed to evaluate for CNS involvement. He was otherwise asymptomatic and didn't have any neurological symptoms or signs after he was switched to ambisome. So the MRI brain that was done showed right temporal cortical medullary rim enhancing lesion with adjacent pachymeningeal enhancement. There were also multiple foci of cortical enhancement with associated edema and leptomeningeal enhancement. So this brings us to the next question for the panelists, which is, what is the opinion of the panel on brain imaging for immunocompromised hosts with possible, probable, or proven invasive fungal infections?
Okay, Ariya or Monica, what should we do? Should we be doing imaging of the CNS for all patients with say proven and probable IFIs?
Well, in our setting, we don't, and that's because we rarely do see intracerebral IFIs. So it's not part of our routine workup for a patient. But this is really interesting. Obviously this could be fungal infection in the brain. It could be a mold infection, but I suppose we still have to keep a bit of an open mind, and the patient has a cavitatory lung lesion, so makes you wonder about TB, stenotrophomonas. He's had a blood culture for that previously. We know that can cause cavitatory lung lesions. And also, of course, there's toxoplasmosis as the very well-known cause of enhancing brain lesions, ring-enhancing brain lesions, occurring predominantly in patients who are highly immunocompromised. So I think all of those things would be going through my mind. So I do think we have to put fungal up high on the list, but I think there are quite a few other differentials as well. So yes, I would try and perhaps get some more imaging and think about biopsying the lung, really.
Yeah, I think your practice would be very similar to ours in Sydney, Monica, but Ariya might have a completely
I think
from
I'm not sure for this case. Because it is from at first from lung, right? And then to the brain. Is there any fever, or do you do any hemoculture on that? Because you have a bacterial infection too, right? How about the hemoculture? Or do you do any cell wall test like Menon? Because you say that you think about the fusariosis. Yeah, but I do not think about the aspergillosis or schizo. Yeah. Why you think that it is fusariosis? Is there any inspiration for that?
So at the point of time when the nodules had occurred, the posaconazole levels were therapeutic. I think the main concerns was the rapid onset of these skin nodules that came on during the period of neutropenic fevers that just raised the suspicion of the team. Blood cultures, multiple sets, as well as fungal blood cultures were drawn, and the serum galactomannan antigen that was taken then was also negative. And so of course, we did think about bacterial causes, higher order bacteria, but what we were concerned was, on top of covering for those, was there a fungal infection that we were dealing with that was progressing as well?
People might need to have some biopsy. I don't think that it is possible to do that. Yeah, I'm not sure for that. If possible, might do the biopsy.
Okay. Are there any infections in sort of more restricted to Southeast Asia, Thailand, that perhaps, we in Australia wouldn't think of, Ariya?
Yeah, right now there are so many weird, we have to say that, uncommon fungal infection. Yeah, like from the plant, yes, or from environment, like some more Ascomystus mold or Basidiomystus mold now is recently increasing for all of that causes. So in this case, we don't have any more information for that, right? We have to investigate what is the pathogen. Yeah.
Ariya, do you think you would consider tularomycosis in a presentation like that?
Monica, is there more comment?
Is it tularo? Like penicilliosis, tularomycosis. Is it a consideration, Ariya?
Yeah. Possible, probable, proven. Any more specimen that we can do it, Dr. Dillon?
Sounds as if we need some clues, Dillon. So why don't you take us through that? Yes.
Dillon, also, I was going to ask if, what's the background of this gentleman? Is he like an agricultural worker? Has he got a farmer or any other exposures to unusual molds?
Fairly unremarkable exposures. Yeah, not an agricultural worker, no exposures to farms. So yeah, nothing that really stands out. I'll move on with the case and give you guys a little bit more information. So moving on, about 5 days after the skin biopsy is performed, the histology report is provided and is available, which shows patchy spongiosis with neutrophilic exocytosis. There's also a presence of fungal hyphae with septations observed on both PAS as well as the GMS stain, located within the vascular lumina associated with perivascular neutrophilic infiltrates. And then around this period of time, the cytology of the BAL fluid also identifies few fungal hyphae on the stains, once again staining on both GMS and PAS. About 11 days after the bronchoscopy is performed, the preliminary culture from the bronchoalveolar fluid cultures identified mold, although the species is still pending.
Yeah, may I ask? Sorry.
Yes.
Yeah, may I? Yeah, okay. Do you plan to have any, or did
Dillon, why don't you go through
you do the KOH preparation for that? The KOH preparation. Do you have chance to perform that?
Yes, we will go through that in a bit.
Yep. Why don't you go through your slides?
Yep. So, we'll move to the next question first before we show, before Dr. Narut and myself will share the findings from each specimen. But the next question that we wanted to explore was what would be the laboratory approach in identifying fungal organisms, specifically molds?
So many of us work in a fungal laboratory, including the attendees that I can see. And I know that Ariya has, both Ariya and Monica have an interest in fungal diagnostics. And we might start with Ariya this time. There you go, Ariya. You have the world at your hand. You have the kind of Center of Excellence laboratory at your disposal. What is your approach to saying identifying a fungal organism? Let's say you've grown it.
I think in my case, I will try to do the most rapid one. Yeah, we can do the KOH preparation with the calcofluor white. Yeah, even you don't have the fluorescence microscope, you can do the KOH preparation at first. Yeah, it depends on the specimen, right, Monica? Whether the specimen is the BAL, right? How much BAL do you have? Yeah, if the BAL is rather mucus-like, yeah, I think it might need to centrifuge that and take the precipitate at that site to prepare for the KOH preparation first, and to see whether the hyphae is which color is hyaline, yeah, or is a dark color. I think it might help at the first step before you're going to do the culture. And we have to also aware of whether it is a non-septate or septate. Right.
Okay.
In case of the non-septate, we have to be careful about matching the specimen. Yeah, because the culture it might die. Yeah. And this is the first time. Monica, any more?
No, I don't think I have anything to add to that. I mean, we still haven't got a culture. We've just got staining at the moment.
Yeah,
so
yeah.
yeah, so of course it will be set up for culture, but it may take some time to grow. So I think your approach is really important.
So let's pretend that we've grown something and, you know, clinicians on our backs to actually make an ID. It's 2025. What would be your, you know, preferred approach to having this organism ID'd? You've got all the tools at your disposal. I think that's what Dillon's trying to ask.
Well, I think you would want to sequence probably. I would probably say that's going to be the fastest way if you can. But, you know, I think some people have used multi-top to try and look at molds, and I'm not sure how successful that is. It works better for Candida, obviously, than for molds. But Sharon or Ariya, you probably know more about that than I do. But I think we obviously like to sequence.
Do you mean the sequence from the culture, Monica?
Yes.
But at this step, they do not have the culture yet, right?
No. If we had a culture, I mean, we could look at multi-top.
Is there any possibility to do the direct sequence from the specimen?
Dillon, this is in your court. Did you consider doing a kind of targeted metagenomics kind of, can we get the organism from the specimen directly?
Yes. So I will get to that.
We'll get to that.
We'll get to that.
Okay.
Yeah.
All
So, thank you so much. I'll just hand the time back to Dr. Narut, who will take us back to the first case with the pulmonary nodule, and then just to, you know, take us through what happened subsequently. Dr. Narut, please.
Okay, and we will now return to the Sierra Hospital cases. Okay, and after that, pulmonologist was consulted, and subsequently biopsy was performed. And here is the official report from the pathologist. They say that the tissue was found angio-invasive and fungal infection with lung necrosis and granulomatous inflammation, and morphologically favor the angio-invasive and mucormycosis, and there is no malignancy seen. And here is a picture of the pathology result. And you can see the broad palsy-septate ribole-like hyphae with right angle branching with lung necrosis and the granulomatous inflammation. And this picture reveals the angio-invasive of this fungus. You can see, and this is a elastin. And sorry. And here is the elastin, and there is the fungal hyphae within the luminal of the vessel, which show the angio-invasive property. Sorry.
Okay, Dr. Narut.
Okay. And sorry. And this one is a GMS stain, which show the broad palsy-septate ribole-like hyphae too. And after 45 days of the culture, and the left side is a picture of the culture in the STA agar and show the whitish hyphae. And when we pick up this hyphae into the light microscope, it show the like a septate hyphae with a brownish spore. So at that time we have no idea what is this organism, so we sent it to the DNA sequencing, and it came back with the result of the Varroa bovaci. Okay, so
Okay.
so
All
this
right.
time I will
So can
let
I just
Dr. Dillon, yes.
Can I just clarify, Dr. Narut, for everyone that you had two organisms. You saw the histology pattern that was consistent with a mucormycete, and you grew this other thing. Is that correct? Or am I got it wrong?
No, at the first time we think that this organism is a mucormycosis, but after we use the DNA sequencing, it shows it's the other species. Yeah.
So this organism that you grew was masquerading as
As
with
mucormycosis.
that was consistent with a mucormycete.
That's
Okay,
right.
very interesting. All right, I think we should now hand back to Dillon for his case.
So, coming back to the case on our side, here we have this gentleman with relapsed AML admitted for his haploidentical stem cell transplant, who now has a mass-like right upper lobe cavitary lesion. And so for this case, we had both a bronchoscopy and a bronchoalveolar lavage performed, as well as a skin biopsy of the new skin nodules from the abdomen that was done. So the bronchoalveolar fluid cultures took a while to grow. After more than 7 days, incubated at 30 degrees Celsius, they found the presence of mold growing on potato dextrose agar, but it only showed sparse white woolly appearance. Under a lactophenol cotton blue stain, it showed the presence of hyphae with abundant globus chlamydospores formed either singly or in chains. And I mean, these photos are with credits to Dr. Tan Ai Ling from our microbiology lab, who also helped us subsequently with the molecular identification via sequencing of the ITS as well as D1, D2 regions, which also did find Vovarella vovacea. So the mold cultured from the BAL was eventually identified and confirmed with sequencing, and tissue from the skin biopsy, while it yielded hyphae, the fungal culture actually failed to grow. ITS was performed on this sample, which also identified the Vovarella species. So this slide just shows some of the differences in how they may appear. I guess owing to different antifungals that they may have received before the specimens were obtained, as well as the forms in which the cultures were grown. So this leads us to the last question for the panelists, which would be, what would be the ideal treatment approach for these invasive fungal infections?
Okay, that would be dependent on whether we see this often enough to know what the ideal treatment. And Monica and Ariya, what do you think?
Actually, I don't know. I have never seen a case of this organism, and I don't know anything about it. So I would be looking up the books to find out more, but Ariya might be more familiar with it than me.
I'm not sure for that too. Yeah, but may I ask to confirm my understanding, Dr. Narut? Yeah, did you do the sequencing directly from the specimen?
We use from the culture specimen from the SDA from the colony.
Okay, you did the PCR from the culture.
Yes, that's right.
Yeah, not from the direct specimen.
Yeah.
Yeah. The second thing is that how about the histopathology? Is there any consistent of morphology? Then because when you show the histopathology staining.
At this time I think that the pathologists may not familiar to this organism like us, so they just interpret what is they look like on their histopathology, but they suspect that it looked like mucormycosis, but after we review that, and as the previous of the literature reviews, the meaning of the case is this organism is look like the mucormycosis as well in the direct specimen. Yeah, so it may be
Yes.
you
You can see, Dr. Narut, if it is possible, do we still have time? Is there any possibility to show the histopathology?
yes.
Yes.
Yeah, you can see the small one. I mean, around 10 to 11 o'clock. Yeah, the small one like this. That is one thing. The second thing is that, yeah, I think that the diameter of the hyphae is not rather the same diameter. So I just think it looks like it might have two organisms together at this staining. It might, I'm not sure. And also you can see on the, how to say, 3 o'clock, like a budding yeast cell, the big one. The big one, this big one, yeah. It may have something that this infection, this mold is not like a parallel for the infection. It just have something like a slant, not in the same plane of infection, like a pythium that is invading.
Okay. I am no histopathologist, but I agree with Ariya that they are probably less fat and broad than you see for a typical mucormycete, and they're not as zigzaggy and irregular as you might. But I can't swear with hand on heart that I've seen enough cases of mucormycetes to know when it's definitely not a mucormycete, as opposed to something like this, which I have not seen. And in answer to Dillon's question, when I don't know what to do, I usually go for the amphotericin, which may not be the right thing to do, but you have a broad spectrum antifungal with an unknown pathogen, and sometimes you just have to try. I mean, this patient sounded pretty sick, and it's a transplant patient, so I'm sure that you're going to tell me that's absolutely the wrong drug to use, and so we'll need some education on this. I'm looking forward to it. So back to you, Narut and Dillon, and to Cherie.
So I'll just hand back the time to Dr. Narut to share the subsequent progress. I can move the slides for you, Dr. Narut, if you want.
Okay.
Okay.
Okay, and following the initial diagnosis, okay. And before the molecular identification was available, the patient was presumed to have the pulmonary mucormycosis, and he was treated with the 2 weeks of intravenous liposomal amphotericin B, and following by the step down to the oral posaconazole with the therapeutic drug level is achieved. After DNA sequencing is unexpectedly identified the Barbarella species in the lung tissue, a repeat chest CT was performed to assess the treatment response. And the CT showed that the original pulmonary nodule is getting improved, but there is a new pulmonary nodule occurred in the hilar region. Yeah. So at that time, we don't know how to deal with this organism, so we decided to add the liposomal amphotericin B back again. And after 1 month later, we follow the CT again. The primary lesion is shrinking, yeah, but the hilar lesion is getting grow up. And at that time, we consulted pulmonologist again, and so they biopsy this hilar lesion, and the histopathological and the pathology is consistent with the CMV pneumonia and also the EBV associated lymphoproliferative disorder or PTLD. Yeah. So at that time, we switched the liposomal amphotericin B and posaconazole to the oral voriconazole, and we give him the ganciclovir for the CMV pneumonitis, and also consult the hematologist to decide to treat the diffuse large B-cell lymphoma, and they give him the rituximab. Yeah, and after that he can discharge from the hospital, and now he's getting better and currently being followed in our outpatient setting. Yeah.
Okay, thank you. Dillon, are you going to now give your follow-up?
So for our patient, following up from the MRI, in view of the CNS involvement, oral voriconazole was started, or rather we had restarted it at a lower dose because previously he had some visual hallucinations. Ambisome was continued until voriconazole levels were therapeutic, and this time he actually tolerated them with minimal neurological side effects. The serial CT imaging showed a stable, minimally smaller cavitary lung lesion. And then later on, when we did a repeat MRI of the brain, the previously seen scattered foci of enhancement as well as the corticomedullary rim enhancing lesion had also resolved. Unfortunately, later on, months later, he developed RSV pneumonitis, and this was complicated by organizing pneumonia with a pneumothorax as well as a persistent air leak, and he eventually succumbed to pneumonia. This is just the timeline of his antifungals that he received. Early on, if we recall, he was started on voriconazole, but developed visual hallucination shortly after. So he was switched back to amphotericin B. He had a course of posaconazole in between, and then we eventually switched back to voriconazole and kept that all the way with minimal changes in his doses until he eventually succumbed to his pneumonia. So this is just an image of the very first CT thorax that was done at the onset of the febrile neutropenia. And this is a repeat about 2 months later, which showed a relatively stable size, although the internal cavitations were less obvious. This is the picture of the MRI showing the rim enhancing lesion at the start, which eventually also cleared off after 2 months. So with that, we've come to the end of our 2 case presentations. I'd like to hand the time back to Dr. Narut as well as Dr. Cherie to go through the literature review.
Okay, so let's do that, and hopefully we'll have some time left over for a general discussion. So, Dr. Narut, are you going first or Dr. Cherie?
Okay.
Yes, thank you.
And okay, so I will review about the Borrelia burgdorferi. Okay, and this organism is also recognized as an eatable mushroom in Asia, and invasive human infection remain rare, and it is like underdiagnosed, under-recognized. And Borrelia burgdorferi, also known as a paddy straw mushroom, which is a thermophilic basidiomycetes, commonly cultivated in and consumed in East and Southeast Asia. And taxonomically, it belongs to the phylum of the Basidiomycota, order Agaricales, and family of the Brutaceae. And this organism is thrive at the temperature between the 37 to the 40 degrees Celsius, and which may explain its pathogenic potential in human, and measure rapidly within the 4 or 5 days after the culture. And to that, and there is a case of the invasive Borrelia burgdorferi infection have been reported in the literature between the 2010 and the 2024. And only one case has the history of the straw mushroom consumption prior to the disease development. Yeah. And in summary, most of the patients were in the middle age of the adults, with the mean age approximately 48 years old. And most of the cases occur in the Asia, and the median age is about the median of the onset is about the 1 month after transplantation or the induction chemotherapy or surgery. Yeah, and all of the patient has the underlying condition, which is the transplantation or the induction chemotherapy. And most of the patient has the organ involvement more than one. Yeah, and the most organ involvement, which is the lung and the brain, yeah, that occur in the 7 patient. And some of them have the skin lesion, and just only one case has the proof of the cardiac infection. And most of the case was treated with the combination between the liposomal amphotericin B and the voriconazole. And some of them treat with the posaconazole, isobuconazole, caspofungin, and some intracranial infection was treated with the intrathecal amphotericin B. And mortality rate is quite high, which is about 60% from this case series. And most of the cause of death is due to from the intracranial hemorrhage. And here is the pathological result from the other case. There is also show the broad septate hyaline hyphae with the extensive angial invasion. And this case, at the first time, they also suspect of the mucormycosis too. And generally, from the culture colony, there is show the pale brown colony and orange mycelia. And if you see at the microscopically, you can see like a copper color globose spore, like our case at the Sierra Hospital. And for the electron microscopy, you can see the character of the basidiomycetes, which is a dolipore formation, yeah, which is the character of the basidiomycetes infection. And I will talking about the each manifestation of this infection. The first one is the most common, which is an invasive pulmonary infection. The patient just had only the symptom like a fever and productive cough, and the contrasted CT show the most common manifestation is the nodules, which is occur in the 5 patient, and the other features are the perilesional gallgrass appearance, consolidation, and cavitation. And some people also show the V-shaped infarction, which may indicate that they had the angioinvasive properties. For the CNS infection, most of the patient has the alteration of conscious, headache, and focal neurological deficits. And MRI finding also show the lesional edema too. And some of them have the brim enhancing lesion and also the meningeal involvement. And just 2 cases has show the like acute infarction. And unfortunately for the CSF profile is usually unremarkable in the most cases. And here is some of the CNS infection. I show you that these 2 cases has like a V-shaped lesion, which may indicate that they has like a angioinvasive properties. And for the skin lesion, that is has a characteristic like the erythematous macule on the skin, and when we biopsy, they show the many of the mycelia under the skin, which may disseminated from the hematogenous spreading. And just 1 case report of the infective endocarditis and can occur. And this case, they have performed like a mitral valve replacement, and the tissue show the fungal infection. And after they identify with the DNA sequencing, there is compatible to the Barbarella valvaceae too. But unfortunately, this case passed away due to the acute hemorrhage at the cerebral hemisphere and pons. And for the susceptibility testing, there is only 2 reported cases that do the antifungal susceptibility. And for the many of the ASO is generally good, except the fluconazole, and amphotericin B is okay. And like this case at the Sierra Hospital, we use the amphotericin B at the first time, and after that we change to the posaconazole. And for now we give him the like a voriconazole and still now give him like voriconazole for like a secondary prophylaxis. Yeah. Okay, and that is my literature review.
Okay, thank you, Dr. Narut. In the interest of time, we will go to Dr. Cherie's presentation, and then we will take questions.
Okay, hi everyone. I think we're running a little bit late, so I will try to zoom through some of my slides. I've been asked to talk about the role of CNS imaging in pulmonary fungal infections in the immunocompromised host. This is a question that's actually plagued me since I was a trainee and continues to plague me today. So the age-old concept of the lung-brain syndrome, I think for our patients with invasive fungal infections, a lot of them, there is a portal of entry for fungal spores into the respiratory tract or sinuses, and CNS spread can take place via direct contiguous invasion from a rhino-orbital odontogenic source, or there can be angioinvasion and hematogenous dissemination to the CNS, and therefore involvement of the lung in the brain. When the fungus reaches the CNS via the blood, it can cross the blood-brain barrier via various mechanisms such as transcellular migration, paracellular transport, or piggybacking phagocyte into the CNS. So the question arises then, in patients, immunocompromised patients with pulmonary fungal infections, should we image the CNS? And I think earlier the panelists did raise their opinions on this. In symptomatic patients, I think it is quite clear-cut. So if patients have headache or altered mental status, seizures or focal neurological deficits, definitely I think none of us would not do a scan, so definitely we'd scan in this case, and sometimes either a contrasted CT or MRI if there are no contraindications. But for asymptomatic patients, most guidelines and recommendations don't actually specifically address this. And so this will be the focus of my discussion today, but with emphasis on common yeasts and molds that affect our immunocompromised patients and cause lung-brain syndrome. And I will not be talking about the endemic dimorphic fungi because these are not so commonly encountered as compared to things like Aspergillus and the molds. So some key questions to address. Number one, why does it matter? Why do we need to know if there is CNS involvement in our immunocompromised patients? It does have some implications on management. So for instance, if the patient has a pulmonary fungal infection and concomitant CNS involvement, we'd want to choose an antifungal agent with good CNS penetration. And often in a lot of our patients with invasive fungal infections, we talk about aggressive surgical source control where possible. And in some cases, if there is CNS involvement with large abscesses in the brain, or they may actually need or benefit from neurosurgical debridement. It does also affect our follow-up and duration of therapy. As we know, we treat our invasive fungal infections until there's clinical and radiological resolution, amongst other factors. And we do want to make sure that the disease, if it involves the CNS, that it resolves before we stop therapy. There are also prognostic implications as there's high mortality associated with CNS involvement. And a second question that I'll try to address today is how common is it? Different species of fungi have different neurotropism and different predilection to enter the CNS. So what are the rates of CNS involvement in the different fungal infections? And how common is it for the patient to be asymptomatic if they have CNS involvement in their IFI? So I'll touch briefly on this because I alluded to it, antifungal agents and CNS penetration. This is a review done in 2019, which talks about drugs, antifungal drugs with good CNS penetration. So generally, they have to be lipophilic with low protein binding, small molecular weight, and also low affinity for efflux pumps. And these are some of the drugs that fulfill these criteria. Within the CNS itself, there is no restrictive barrier between the interstitial fluid of the brain parenchyma and the CSF. And so once the drugs enter the CNS, the drugs can actually move freely between the spaces. but the concentrations often are not equal or they don't equilibrate because of many different factors, including drug clearance. So this table is quite a helpful one done in this paper where they talked about antifungal drug penetration in the CSF as a percentage of the serum concentration. I would like to highlight that for the azoles in general, most of them have pretty decent brain tissue penetration as compared to the percentage of the serum concentration. Maybe posaconazole slightly lower, but there's also been clinical success reported with use of posaconazole. For CSF penetration, it appears that itraconazole and isavuconazole may not achieve such good levels in the CSF. Posaconazole was quite variable. The echinocandin agents, as we know, have poor penetration of the CNS in general, so these are not recommended, and there is not much clinical success using these agents for CNS infections. And amphotericin B-based agents, they do have, they do not achieve such a high percentage of serum concentration in the CSF, but generally the concentrations that enter the CNS are usually fungicidal, and that's why they can work, and there is clinical success with their use. And as we know, flucytosine has good CSF penetration as well. So this is a paper by Mathiazuti in 2005, where they talked about the different types of common fungi that can affect the CNS, and there are different predilection for entry to the CNS. So for instance, you can see that Cryptococcus has a very high predilection for the CSF, and the molds like Aspergillus and the Mucorales group, Ozygomycetes, also have quite a high predilection for the CSF. They do manifest differently. So for instance, our molds tend to cause more abscess or cerebritis changes, and because of their angioinvasive properties, they also can cause infarctions and complications from angioinvasion. Whereas Cryptococcus and, for example, an endemic fungi like Coccidioides tends to cause more meningitic kind of symptoms. I did another dig through of other literature as well, and this is my own summary for people who like words more. But basically, the bolded areas are the ones that are more common. So I would also like to highlight that molds tend to cause abscesses or cerebritis changes, like our cases presented by Dr. Narut and Dr. Dillon. And they do also have quite a high rates of angioinvasion, and therefore can cause complications related to angioinvasion like infarction, bleeding, mycotic aneurysms, and they tend to manifest as meningitis less commonly. The rates of CNS involvement in the fungal infections, this needed a little bit of digging to find, but it's quite varied, but you can see that this actually correlates with some of the tables I showed you earlier. In immunocompromised patients, Cryptococcus has a very high rate of CNS involvement. So patients with cryptococcal infection in the literature, 44 to 84% do involve the CNS. For the molds, it does range between 10 to 20%, and as goes for histoplasmosis as well. So I will touch on a few of them. I just like to focus on Cryptococcus, Aspergillus, and Mucor just to demonstrate a few key concepts. So I mentioned earlier that Cryptococcus has a high propensity to enter the CNS, very high neurotropism. This was demonstrated quite well, I thought, in this paper by Wake and colleagues in CID, where they looked at a very large cohort in Johannesburg with 19,000 patients with HIV, low CD4 count, and positive serum cryptococcal antigen. And they actually examined the CSF in 90 asymptomatic patients. So these patients had positive cryptococcal antigen in the blood, but no CNS symptoms. And they actually confirmed meningitis in 34%, 1/3 of the patients who had no CNS symptoms. And they found that the cryptococcal antigen titer in the blood was significantly associated with predicting meningitis. And if the titer was very high, more than 160, it had a very high sensitivity to specificity of predicting CNS disease. So this is the basis of the recommendation in a lot of the guidelines, where in patients with HIV and low CD4 counts, then you need to maintain a very high index of suspicion for CNS involvement, even if they're asymptomatic, because 1/3 of them can actually have meningitis. In non-HIV immunocompromised hosts, we don't have similar studies or literature, so a lot of the recommendations are extrapolated from patients with HIV. So in the IDSA guidelines, it does mention that if you have an immunocompromised patient with pulmonary cryptococcosis, meningitis, or CNS involvement should be ruled out by lumbar puncture, as it will alter your therapy and intracranial pressure monitoring. If your patient is not immunocompromised and they have just pulmonary cryptococcosis, if the patient has no CNS symptoms, very small nodule, low or negative serum cryptococcal antigen, then the lumbar puncture can be avoided. Now, these guidelines don't specifically address imaging of the CNS, but I think if I were to kind of draw conclusions from this, if an immunocompromised host has pulmonary cryptococcosis but no CNS symptoms, we would definitely plan for an LP based on what we discussed earlier. And I think most of us would probably do some kind of imaging before we plan for an LP. Immunocompetent host guideline is not so, I mean, it will depend as mentioned. And unfortunately, unlike in Cryptococcus infection, there is actually simply not much literature describing the rates of CNS involvement in asymptomatic patients with invasive mold infections elsewhere. So for example, patients with pulmonary mold infections, how many of them have CNS involvement if they're asymptomatic? The literature is really quite scarce. I had to do quite a lot of digging. I even had to go to very old literature, which are basically autopsy reports, or autopsy-based studies from way back in the day. And so this is one review by Young et al. In 1970, where they looked at 98 cases of Aspergillus in their center from autopsy records. 13 of their 98 patients, 13% had CNS involvement, and all 13 of these patients had disseminated disease. And in most of them, the primary lesion was the lung. All 13 of these patients manifested some form of CNS signs and symptoms, according to this paper, some kind of lethargy, obtundation, depression, and many had focal neurological deficits in signs, as I've highlighted here in the green box. You will see that they had a lot of interesting neurological signs. But I would add the caveat that this is an autopsy series and there's probably overrepresentation of more severe and disseminated cases, so we do have to interpret this with caution. What was interesting also, because this is an autopsy-based study, they actually managed to look at the histology from the patients with CNS aspergillosis. And a very striking histological characteristic was actually vascular invasion with secondary thrombosis of the cerebral vessels, which is shown here in the photo. And this was present in 10 out of 13 of their patients. So the symptoms that the patients present with may not only just be due to the abscess or cerebritis itself, but as a complication of the angioinvasion, so bleeding, infarction, and the like. So this is a more contemporary paper, not so long ago, where from Mass Gen, where they looked at a case series of 14 consecutive patients with CNS aspergillosis that were admitted to their center, and they looked at their symptoms and presentation and outcomes. And the majority of the patients in the Mass Gen series actually had neurological signs and symptoms, so 11 out of 13 of them. Only one of the patient number 3, had only fever and no specific CNS symptoms, and one of the patients, number 9, who had no clinical symptoms reported or captured. This is also another paper, a systemic review by Mina and colleagues, where they looked at all patients with proven CNS aspergillosis, and they included 175 articles and 235 patients in their analysis. You will see that the neuroimaging findings most commonly was abscess, which is what we see in clinical practice as well. And a lot of them, majority of the presentation, were things like headache, vocal neurological deficits, and they could also present with cranial nerve palsies, altered mental state, or seizures. This paper actually did also highlight that 12% of the patients in their systemic review, they found that the patients did not have any specific CNS symptoms, but had constitutional symptoms like myalgia, loss of weight, loss of appetite, or fever. And so this comes back for a mini summary. Should we image the CNS in immunocompromised patients with pulmonary aspergillosis who have no CNS symptoms? So I think based on what I've seen, or what we've seen, a majority of patients who have CNS aspergillosis would be symptomatic, either from the abscess cerebritis itself or angioinvasion with its attendant complications. If they have no CNS signs or symptoms, there's actually no strong recommendations in our current guidelines to routinely image the CNS, which corresponds with the literature. But through the digging of the literature, I think it was concerning to me that 12% of patients may not have CNS-specific symptoms as demonstrated in the MENA systemic review. And sometimes the symptoms may be subtle or non-specific initially, and they can progress rapidly once the aspergillus invades the vessels. So if we're choosing not to image the CNS, which is reasonable, we do have to maintain high vigilance with a low threshold to scan if there is any new symptom development. I will also touch on mucormycosis. Involvement of the CNS in mucor occurs most commonly, frequently due to contiguous spread from the paranasal sinus and orbits, usually seen in diabetic patients. This is a majority of the cases, and usually this will be quite obvious, and most of these patients will end up getting imaging of the sinus, the orbits, and the brain because they're all there. So this is not the ones that we will be worried about in asking this question. The frequency of CNS mucormycosis does vary depending on the underlying risk factors. This was a nice summary from Cherie and colleagues, where you can see that in patients with malignancy or stem cell transplantation of typical immunocompromised hosts, where we may see disseminated hematogenous dissemination, the rates are about 12% where they can involve the CNS. So it also enters the CNS by going through the vessels and then leading to thrombosis, ischemia, infarction, and hemorrhagic necrosis. And this necrotic hypoxic environment does limit immune cell activity and antifungal penetration. Direct hyphal invasion of brain parenchyma actually occurs late in the disease and is usually a pre-terminal event. So the typical symptoms of CNS mucormycosis, I think rhino-orbital mucormycosis, we would have, sinusitis, orbital cellulitis kind of presentation with proptosis, chemosis, and if it progresses further to invade the cavernous sinus, they can even develop signs in the contralateral eye, and they typically have a lot of necrotic eschars, which are quite visibly apparent. In disseminated disease, where it disseminates from elsewhere, for example, from a pulmonary source, they can present with, similarly like to aspergillus, they can have headache, hemiparesis, focal deficits, altered consciousness, or seizures. In this review by Pagano, where they looked at 59 patients with heme malignancy with proven or probable mucormycosis in their hematology units, they found that CNS involvement was observed in about 19% of their cases and was always associated with other sites of infection. The varying presentations were observed in the patients with CNS involvement, some just with fever and some with CNS localizing symptoms. And when they looked and they focused on the 38 patients with the lung as deemed as the primary site of infection, 18% had concomitant CNS infection as shown in this table here as well. So in mucormycosis, should we image the CNS in patients with pulmonary mucormycosis who have no CNS symptoms? It seems from the literature that the CNS involvement is often associated with disseminated disease, and the symptoms may not always localize to the nervous system. Immunocompromised patients with the lung as a primary site of infection seem to have fairly high rates of CNS involvement. I think it was 18% in the earlier slide that I showed. And CNS mucormycosis, as we know, can progress rapidly with very high mortality, and generally we tend to be quite aggressive in the management to try to debride what we can and reduce the load because this highly necrotic environment limits antifungal activity or penetration. So the global guidelines in 2019 published on management of mucormycosis actually has a line written in the text where they mention that if mucormycosis has been proven in the patient with underlying malignancy, they do recommend for cranial, thoracic, and abdominal imaging to determine the extent of disease with moderate strength. And I suppose the reasons are similar to what we mentioned. So some conclusions and takeaways if you've gotten confused by everything I was saying. I think number one, identifying CNS involvement in immunocompromised patients who have pulmonary invasive fungal infections does impact our antifungal choice, potential need for neurosurgical intervention, duration of therapy, and prognosis. In immunocompromised patients with pulmonary IFI, should we image the CNS? If the patient has symptoms, definitely yes, this is without a doubt. If they have no CNS symptoms, there's no one-size-fits-all approach. Different fungi have different predilection for the CNS. So for example, Cryptococcus has very high neurotropism and we always want to check for CNS involvement. If the patient has an invasive pulmonary mold infection, CNS disease may occur without focal symptoms initially and can progress rapidly. So if choosing not to image the CNS, we do need to maintain vigilance and a low threshold to scan if symptoms progress and new symptoms develop. Yeah, and with that, that's the end of my segment. Thank you for your attention.
Thank you, Dr. Cherie. Van Hock, I've been sort of stealing the stage and bad about it, so I think I might hand over to you for the last segment of this. I think there are a few questions in the chat, and I've really enjoyed this, and I've learned a lot tonight, and I will never look at another histopathology specimen that looks like muco and assume it's definitely mucormycosis. Thanks, Van Hock.
Yeah, thank you, Sharon. Thank you also to the two speakers for their excellent literature reviews. Yeah, let's go to some of the questions now. The first question, I think, is actually for the presenters, Dillon and Narut. Did you do sensitivity testing? I think that was the question.
For the SGH case, I think microsensitizers were attempted, but because of the poor fungal growth from the specimens, I think it was unsuccessful.
Okay, okay. And Narut?
Yeah, and in our hospital, we asked a microbiologist to try to do the same thing like the Dr. Dillon said, but it also failed too. We had the same problem.
Yeah, I also think it would be very difficult, and of course, we wouldn't know how to interpret the results. That's the other thing. Somebody asked the two of you whether or not they are real cases. I think we can assure everyone that these really happened. As you can see, the two presenters provided quite a lot of detail. Yeah, I invite all the members of the audience to continue typing into the Q&A section if they have questions. May I ask the two speakers whether or not the two presenters whether or not a history of mushroom exposure was taken after you found out the identity of the bug?
And for my case, I have asked the patient that whether he exposed to the mushroom or not, and he denied the history at all. Yeah, and our hospital did not serve the pathosort mushroom to the patient during the hospital too. So we have no idea how it come. Yeah.
Dillon?
For us, I don't think there was a very clear exposure history. Yeah.
Okay, okay.
But a quick question.
Yes, Sharon.
For both Dillon and Narut, this organism grew very, very slowly. Yes. So I think that's a clue. But could you get it to sporulate as well? Could you get it to sporulate?
May I answer? Yeah, you mean the
Yes.
yeah, okay. Do you mean this mushroom can sporulate or not, right?
Yes.
That is your question. Yeah, actually, Dr. Narut already show you also that both of you already show the chlamydospores.
Okay.
Yeah, that is in the culture. But if you grow them in the straw or in the field, It can
Right.
show you like a mushroom. Yeah. I just have a big quick question. Yeah, I'm not sure whether how about the relatives or any friends that come to visit
Why?
the patients. Yeah, because when the anyone visitors came to visit the patients, if they are in the field, it might come with the cloth with a lot of mushroom, a lot of hyphae. There is something might be possible like that.
On their clothing, you mean?
Yes, it might be possible.
Oh, that's very interesting.
Mhm.
That's an interesting thought. Yeah. Are there any more questions?
I don't know. They're both very, yeah. Any
Go on,
questions?
Karen.
Oh, they're both very highly immunocompromised. So I guess they have a reason for the IFI. It's just a question of where the source was. And the Singapore case had no contact with the case from Thailand, right? So they're completely separate events. Yeah.
Yes.
Just trying to get a link.
For sure, they had no contact with one another.
Yeah.
So in general, how would you approach these very rare fungi? Because we do see them off and on, unusual names and all that. Monica, you were saying you would go to the book or something. Would you like to elaborate?
Yes, so I think I would look up the case reports that have been published and try and figure out how I was going to treat this patient. And now I know, thank you to these very nice literature reviews about what I should treat with. But yes, I think they're fascinating cases, and maybe we are seeing more of these basidiomycete infections occurring, or maybe they're just being identified more commonly. But I think it is a really kind of growing area that we're really going to have to expand our knowledge on. And I don't really know, apart from the fact that they are these straw mushrooms, if there's any other environmental niche for them. Like some of the other basidiomycetes grow on wood, the wood fungus and rotting materials. But I don't think that the patients would have come in contact with these in the hospital. I find that hard to believe. So it's very unclear where they've come from. And just like Aspergillus, could a patient come into their transplant already colonized with one of these organisms, and during the immunosuppression, it becomes more invasive? I don't know. I don't think we know enough about the natural history of these infections as to whether it's possible the patient was already colonized and it really just became apparent after immunosuppression. So I think there's a lot of questions, but definitely I'd be taking a bit of a walk around the wards and just checking that there aren't any potential sources in the ward where these patients are looked after, any kind of air leaks or mouldy areas around the wards. We don't usually find that, but sometimes in an older hospital there could be something going on, some renovation. So I'd think about all of those sort of things, but in the end I think we're a bit stumped as to where these infections have come from.
Yes, thanks, Monica. I think that's the problem, isn't it? That people don't define an incubation period for these molds.
Exactly.
Yeah, we actually, you're right. We actually don't know whether they came into a hospital with them and then something made them invasive. Yeah, I think we are hitting 6:30. So and we've had a very interesting discussion. It's December, so I think we should end a minute or two earlier. Thank you very much to the two expert panelists for joining us. Thank you, of course, to the speakers, Narut and Dillon, for presenting very fascinating cases, and to both Narut and Cherie for doing a very illuminating literature review. I think it's been truly educational. We have 2 announcements for you. Pravi, can you show the slides? We are doing, oh yeah, there's a feedback survey. So please fill up the survey form. And then we are holding this ISHAM Asia in Kuala Lumpur next year. So there's a pre-congress workshop, which is a little bit more basic. So you can send your laboratory staff or your trainees. And then there's the congress proper. So it's there on the AFWG website. You can also follow us on Instagram or Facebook, and you can scan the QR code. And then there's one more announcement. Oh, yes. So for your friends who may have missed this because they're still working, I know that it's a bit early in the afternoon for people in India and Pakistan, and slightly a bit late maybe for people in New Zealand. So if you want to catch the replay, it's on tomorrow on YouTube. So thank you once again. We are 8 days from Christmas. So Merry Christmas to every one of you. Thank you and good night. Back to you, Sharon.
I just want to, reiterate your thanks to all the speakers, to Narut, Dillon, and Cherie for a very comprehensive, entertaining session, and to Monica and Ariya for giving up their time to be on the panelists and helping us with the discussion of the cases. And of course to you, Ban Hock, and to all the AFWG Secretariat. Thank you very much. So I'll see you next time, and our next session will be presented by ANZMIG in February next year, February or March next year. So see you then.
Bye-bye.
Do with the music.
Thank you, Sharon.
I'm not sure what we're doing with the music. Maybe you better be enjoying it. Okay, let's enjoy it.
I think we should do the 4th session. Yeah. Okay, thank you.
Okay.
Very nice job to all the presenters. Thank you. Thanks for having me. Bye-bye.
Merry Christmas in advance.
Yeah, Merry Christmas. Bye-bye.
Good night, Monica.
Good night. Night, everyone.